Okay, so ladies and gentlemen, today we have Dr. Isabel Rubio joining us from Madrid in Spain. Thank you, Dr. Isabel, for joining us. Dr. Isabel will be talking about the management of axilla after neoadjuvant treatment. Dr. Isabel, the floor is yours.
Okay, well, good evening, everybody, and thank you for the invitation to participate in these webinars. It's a pleasure for me. So I think I will give the lecture and then we will have some time for questions. So the lecture today is about the management of the axilla after neoadjuvant treatment. And okay, these are my disclosures. And we already know that there are some advantages from the neoadjuvant treatments. One is to monitor the response to the therapy at an early stage, to downstage the tumors, to be able to do breast conservative surgery, and in the last 5 or 8 years, to de-escalate the surgical treatment of the axilla. It's also one of the advantages, and we will go through this in the whole time. Also, it will give us some time to provide with germline mutation test. It's true that in many cases there are, in many hospitals, the mainstream genetic testing that can get the test in a couple of weeks, but in some others needs a little bit more of time. So it will give us time to have results from the genetic testing. But not only that, the other advantage that we have seen in the last decade is that it can provide post-treatment prognostic information for adjuvant treatment, mainly in those patients with HER2 positive and triple negative breast cancers. And also it will help to expedite the drug development. So this is like a table where you can see the different changes over the years in managing the axilla. And we can see that in the 70s, all patients with breast cancer underwent an axillary lymph node dissection in the 70s and 80s. Then in the 90s, it came the sentinel lymph node biopsy for those patients with a clinically negative axilla. And we have the results from the NSABP-B32 and the Milan trial. The 2000s, we start seeing that in those patients with clinically negative axilla and positive sentinel lymph node biopsy, we stopped doing an axillary lymph node dissection if the indications were there from the different trials. And then we came in 2010, when we start looking into the sentinel lymph node biopsy in those patients with neoadjuvant treatments. And we have the results from different trials that has shown us the feasibility and the oncologically safety of doing a sentinel lymph node biopsy after neoadjuvant treatment. And then probably the next step would be in which patients we can avoid a sentinel lymph node biopsy or any surgery in the axilla. And we will mention some of them in the neoadjuvant setting. I'm not going to mention anything in the adjuvant setting, so we will give it for the neoadjuvant treatments. Of course, there are different approaches, whether we have a patient with a clinically negative axilla or a clinically positive axilla. It will differ the type of axillary surgery, and it will differ also the type of radiation therapy. So in those patients with a clinically negative axilla, we know that sentinel lymph node biopsy is safe, is accurate, and we know that from meta-analysis and from different trials looking into false negative rates around 8%, 7%. But we already know from the adjuvant setting that the really false negative rate does not translate into an increased local recurrences. But when we look into the follow-up in these patients with a clinically negative axilla and a sentinel lymph node biopsy, and we have the studies here from the Italian group, from the French group, looking into a follow-up of more than 10 years, and the regional recurrences in the axilla are very low. So because we know that in those patients with a clinically negative axilla, sentinel lymph node biopsy after neoadjuvant treatment is safe, can we find a select group of patients where any axillary procedure can be spared? And this is this idea came from the studies looking into those patients with HER2 positive and triple negative breast cancer. And you can see here different studies. Those patients with a clinically negative axilla who undergo neoadjuvant treatment. And they have seen that in those patients with a breast PCR, the chances of having a positive axilla are really almost 0% and below 2%. We know from different studies that in those patients with a clinically negative axilla, when they undergo neoadjuvant treatment and then the sentinel lymph node biopsy, less than 5% in general across all the subtypes will have a positive axilla. Well, if we reduce this to the HER2 positive and the triple negative, this rate of positivity goes below 2%. So it seems that in this group of tumors, the breast PCR, the pathologic complete response in the breast, is highly correlated with the nodal status. So maybe these are the group of patients where we can avoid a sentinel lymph node biopsy after neoadjuvant treatment. And there are a couple of clinical trials going in this group of patients, the EU breast, where the omission of sentinel lymph node biopsies in triple negative and HER2 positive breast cancer patients who has a radiological complete response and then a pathologic complete response in the breast after the neoadjuvant treatments. And the one from the Netherlands that it's similar, but it includes also patients with luminal cancers. So looking into the one of the EU breast one that we are participating in this one, so the patient has a biopsy proven of triple negative or HER2 positive breast cancer that is clinically negative axilla. Then the patient undergo neoadjuvant treatment, and when we do the evaluation for the response after the end of the treatments, the patient has a radiological complete response. Then the patient needs to go to breast conservative surgery. If it's going to mastectomy, they cannot enter in the study. So if the patient is indicated to have a breast conservative surgery, then the patient signs the consent forms. We do the surgery, just the lumpectomy, and then if there is a PCR in the breast and it is allowed to have residual DCIS, we don't do an axillary sentinel lymph node biopsy. If by any chance at the end the patient do not have a PCR in the breast, then the patient will undergo a sentinel lymph node biopsy, but this is the group that is out of the study. In those patients with no axillary sentinel lymph node biopsy, the primary endpoint will be the axillary recurrence-free survival, and the first analysis will be done in 3 years. As far as now, the trial will be closed by the end of the year. It was expected to have 350 patients. We are very close to get to the point to that number, and at that time it will be closed. So we will probably have definitive results of this trial by 2027, 2028. So what about those patients with a clinically positive axilla? Well, we know from all the studies in the 90s and the 20s that in those patients with a clinically positive axilla, there is a conversion from node positive to node negative after neoadjuvant treatment that can go as high as 45%. And you can see this is the trial from the NSMEP V27. These are the first trials where the neoadjuvant treatments were applied. But we have seen, and this is from our group, that in those patients with HER2 positive breast cancer, this conversion from positive nodes, clinically positive, to pathologically negative after neoadjuvant treatments can go as high as 70%. And this can be even higher if the patient has a negative hormone receptors and a HER2 positive breast cancer. So in this group of patients where in the last decade we were doing an axillary lymph node dissection, can we do just a sentinel lymph node biopsy and no axillary lymph node dissection? Because what is the point of removing all the axillary lymph nodes if the patient has a complete axillary response? And we have the results from these 3 studies that already you know about them. The ACOSOC 71, the SNAC, and the Sentinel, looking into those patients with positive axilla before neoadjuvant treatment who undergo a sentinel lymph node biopsy, and the false negative rate, as you can see here. The lowest false negative rate is the one when you use a dual tracer. When you have more excise, more than 2 sentinel lymph nodes, and usually in those where you consider isolated tumor cells as a positive node. In those group of patients, the false negative results are below 10%, but still it seems that it was a little higher. And as I mentioned before, from the adjuvant setting, we know that this does not correspond to increase in axillary recurrences, but we really didn't know in the neoadjuvant setting, because in the neoadjuvant setting, the patient has already had all the neoadjuvant treatment. So this seems to be that probably are nodes that who has not responded, and maybe, you know, we are leaving disease in the axilla that will be untreatable. So because there was this worrisome about this 10% of false negative rates, there were many studies looking into other type of axillary surgery. Because as I was mentioning, the false negative rates after neoadjuvant treatments can mean a different thing than in the adjuvant setting, because we can misrepresent the prognosis. And we already know that in those patients with triple negative breast cancer and HER2 positive breast cancer, if they don't have a complete response, there has been a study shown that different adjuvant treatments will improve their prognosis. So if we don't see this residual tumor and we left it behind without unknowing, we probably leave the patients with the probability of having additional treatments. And of course, you know, the role of radiation therapy would change if we miss this positive axilla. Of course, the axillary ultrasound can be of help, but we already have seen from different studies, from the ACOSOC 71 and from the other studies, that they are not as accurate as we would like to see after the neoadjuvant treatment. So in the ACOSOC 71, when after neoadjuvant treatment there was a negative axillary ultrasound, you can see that the false negative rate was still 15%. But what is more worrisome is the positive axillary ultrasound after neoadjuvant treatment. That means that there is a false positive rate of 29%. So it means that if we just follow the ultrasound after neoadjuvant treatment and before the surgery, we will probably be doing more axillary lymph node dissection to those patients who underwent a conversion to node negative. So the abnormal ultrasound after neoadjuvant treatment is not enough to triage the patient to a sentinel lymph node biopsy or to an axillary lymph node dissection. So if there is any doubt about what to do, probably it's better to do a biopsy of the node before the surgery. And the same results were found in the other studies. So probably the ultrasound is the best thing that we have, the best method of imaging after neoadjuvant treatment for the axillary nodes, besides the PET-CT that I'm not gonna mention because it's not really done in many places, except in the Netherlands. But I think it's the best one that we can have. So the other question came into place when we decided whether we need to put a clip on the node that was biopsied and was positive, or we can just excise the sentinel lymph node without it. And you can see here different studies looking into placing a seed, a clip, an intraoperative ultrasound and the clip, black ink, and so many. And you can see, sorry, that the false negative results are mainly below 5% in the majority of the cases. So in these cases, we've seen that if we place a clip, then the false negative results will be lower. And then I'm going to show you how do we do it with the intraoperative ultrasound. So you can see here the clip. We do the ultrasound. We also check with the sentinel lymph node biopsy. We open the axilla. See that we have a very small probe that we put inside, and we can see the clip node. We check with the probe also for the sentinel lymph node biopsy. Then we excise. We always check, and you see the clip here. We always are checking with the probe. And we always check with the sentinel lymph node biopsy to see if the clip node is the sentinel lymph node biopsy. We excise it, and we make sure that we are excising the one that is the clip node. Because if we lose it, it will be difficult. See, we check, and it's there. This is the clip node, the clip that is here, and the node. We check, and in this case, you see it's also blue because we usually use radioisotope and blue dye. We excise it, and we check again, and you can see here the clip. In many cases, you see the node, and in some cases, see the node just there, and in some cases, you don't see it. And we did a study looking into the data from our results in the intraoperative ultrasound, and you can see here that we found with 250 patients that the false negative results was around 7%. But if we excise more or equal to 3 nodes, it goes below 5%. Of course, if we only excise the clip node, then the false negative rate was really high. And this is important because still, even though we are clipping the node, we've seen that if we don't excise at least 2 nodes and the clip node, the false negative rate will be higher. Of course, what is the follow-up in those patients with a clinically positive axilla before neoadjuvant treatment, a sentinel lymph node biopsy and no axillary lymph node dissection? And what is interesting is the group from Galimberti, where they only excise 1 or 2 nodes, no clip, no nothing. Axillary failures were very low with a median follow-up on 10 years. But also the group from Memorial has shown that without clipping the node, excising more or 3 negative sentinel nodes, there was no axillary recurrences after a follow-up of 40 years. And there was only 1 axillary recurrences, but it was mainly in a patient who didn't have an radiation therapy. So it seems that this type of axillary surgery, whether you use the clipping of the node and any other type of how do you excise the clip, whether it's a magnetic seed, whether it's a intraoperative ultrasound or whatever, or if you don't put any clip, but you just do the sentinel lymph node biopsy and you have already known your false negative results, you can do both. And it seems that if there is a conversion from positive axilla to a negative axilla, it means that the patient will do fine and the axillary recurrences from the studies are very low. Of course, you know, there is this study just published and presented last year in San Antonio, where you can see, and this is very actual data from the last years with more than 1,000 patients. And in those patients with a 66% of pathologic complete response in the axilla, that is really a very, very high number. Mean number of removed lymph nodes were 3. So this means that we are removing 3 lymph nodes at least in this type of patients. And when you look into the local recurrence rate at 5 years, they are very low. 1%. The axillary recurrences at 3 years, very low in the group who undergo targeted axillary dissection, meaning putting a clip or any other marker in the node, or whether the patient has a sentinel lymph node biopsy. And I think this is important data because this is data, very prospective data from different groups and different type of doing the axillary surgery. And then the question comes, when the sentinel lymph node is positive, do we need really to complete an axillary lymph node dissection? And from the studies that we have seen before, the 71 and the Canadian and from data from Memorial, has shown that in macromets there is more than 50% of chances of having additional positive non-sentinel nodes. But also when the node has a micromet, you know, the chances of having additional positive nodes is high. And regarding the ITCs, you know, I may say that the numbers are high of having additional positive nodes, but if you look into how many patients with ITCs, it's very low. And the data from the new data from the Oncoplastic Consortium shows that these numbers are much lower. And in many cases, there is no differences in doing an axillary lymph node dissection.
What is ITC?
Isolated tumor cells.
Okay.
So we've been talking about mainly in those patients who undergo neoadjuvant treatment, but what about in those patients who undergo neoadjuvant endocrine therapy? Because we know that when the patients undergo neoadjuvant endocrine therapy and not chemotherapy or chemotherapy plus target therapy, the rates of axillary pathologic complete response are much lower, even though in the breast are much lower. But if we look into these two different data sets from the States, in those patients with a clinically negative axilla before neoadjuvant endocrine therapy, you can see that in the majority of the patients, the axilla remain negative. Of course, the numbers are lower than in the chemotherapy patients. But if we look in the patients who had a positive axilla before the endocrine therapy, neoadjuvant endocrine therapy, you can see that the rates of conversion to negative axilla are very low. But what does this table mean? This means that probably in some patients, we can spare an axillary lymph node dissection because the majority of the patients, and you can see here with 1 or 2 nodes, the rates of having additional positive nodes are very low. And also in the patients with a clinically negative axilla, the chances of having 1 or 2 positive nodes are below 1/4. So I think that we don't have enough data in these patients to change what we are doing in terms of the management of the axilla in the neoadjuvant setting after neoadjuvant endocrine therapy, but this is something that we have to look into it. Of course, there is always this question about, you know, we are de-escalating the axillary surgery, but what about the radiation therapy? Because at the end, if we de-escalate the axilla with surgery, but we are irradiating more patients, then, you know, the morbidity of this type of management will still increase the lymphedema. And we will have to wait a little bit for the different trials. And you have here the Alliance trial that it's already closed, so we will have the results in a few years. In those patients with T1, 3, and 1 at diagnosis who undergo neoadjuvant treatment and still has a positive sentinel node, this study will look into the addition of radiation therapy to the axillary lymph node or radiation therapy alone. And also in those patients, the NSIBP51 is in those patients with a positive axilla. And if there is a conversion to sentinel lymph node negative, do we need radiation therapy or not? And there are many others from Europe, the GANEA3, the NeoNode, and the other ones that we look into the value of radiation therapy and axillary lymph node dissection in those patients. Of course, as I was mentioning, we are de-escalating the axilla, but what about the de-escalation of radiation therapy? And the only study that we have now after primary chemotherapy is this study from the Netherlands, that what they do is they classify patients with low risk, intermediate risk, and high risk patients to evaluate whether the patients will receive the different radiation therapy. So in these patients with clinically T1 to N1 patients who receive neoadjuvant treatment, and then they have agreed to classify a low risk in those patients with complete axillary response, pathologic response, intermediate risk, or high risk. And depending on this, they give radiation therapy, no radiation therapy, or they give local or local regional radiation therapy. What they have found in this series is that the 5-year local regional recurrence is very low in all of them, but also in those patients that are at low risk and do not receive regional radiation therapy if there is a conversion of the axilla after the neoadjuvant treatment. Of those, the hypothesis is that with less than 4% of a local regional recurrence rate at 5 years, it might be safe in very selected patients to de-escalate the local regional radiation therapy. And this is important because, this is one way to start doing until we have the results from the randomized trials that I mentioned before. Of course, there is a great variation in how we manage the axilla when we have a patient with a macrometastasis or micro or isolated tumor cells. And this is a survey that was done in Brazil last year. And you can see that there was 800 questionnaires returned. So this is really good because the surveys are not really very well answered. And as you can see, in those patients with a macrometastasis, the majority of the breast surgeons do an axillary lymph node dissection. Whether the patient has a micrometastasis in the sentinel lymph node, the rate of axillary lymph node dissection decreased to 64%. And in the case that the sentinel lymph node has an isolated tumor cell, then the rate of axillary lymph node dissection will go to 1/3. Of course, the rates of radiation nodal irradiation, as you can see, are also very different from the different survey. Even in some of the patients, 2% of the patients with a macrometastasis in the sentinel node, the patient didn't receive any treatment. So I think it's important to have definitive results of the prospective trials to be more homogeneous in the way we manage the axilla. So if we may conclude, I think that the sentinel lymph node method in the neoadjuvant setting, in the preoperative systemic treatment setting is crucial because we have reduced the rates of axillary lymph node dissection in many patients. But it's true that we need to standardize the treatments and we need to know our own false negative results. So to all these groups that are starting with the sentinel lymph node biopsy after neoadjuvant treatment, I think it's important to know their own false negative results before starting to sparing an axillary lymph node dissection in those patients who has a negative axilla and were positive before the neoadjuvant treatments. Actually, what we do is that in those patients with a clinically positive axilla who convert to negative, we spare an axillary lymph node dissection. If we always clip, as I show you in the video, we always use intraoperative ultrasound, and we do the sentinel lymph node biopsy. We will have to see whether no axillary surgery can be done in those patients with a clinically negative axilla, selected patients who had a pathologic complete response in the breast and has a clinically negative axilla before neoadjuvant treatment and after. The sentinel lymph node biopsy after a clinically negative axilla is safe, I believe that we have seen that similar to the adjuvant setting, the false negative rates do not equal the axillary recurrences. And I think that at the end, like anything in surgery, the selection of patients is the key for the escalation of the axillary lymph node dissection. So there are many questions that remain. And one of it is, would it be possible to predict an axillary PCR? As far as now, we don't have a really excellent imaging to do that. Can we use the circulating tumor cells, biomarker, do biopsies first to predict the axillary PCR and avoid any axillary surgery in those patients? We will have the questions related to the omitting sentinel lymph node biopsy in those patients with clinically negative axilla and a breast PCR in 2 or 3 years. Of course, we will have to wait a little bit more for the long-term prognosis in this de-escalation, and not only in the oncological outcomes that are really important, but also in the functional outcomes. We will have to see whether doing just the sentinel lymph node biopsy and that procedure and excising 3 long lymph nodes, and in the majority of these patients that will have a radiation therapy, would it impact the functional outcomes? And I think that's also very important. And then, as I mentioned before, we will have to wait to see what happens with the radiation therapy if we de-escalate the surgery, if we can identify those patients who has a low risk of regional recurrences, and we can also de-escalate the radiation therapy. And just to finalize, I just want to invite you all to the next European Society of Surgical Oncology meeting that will be held in Antwerp the next October. So thank you very much again for the invitation to be here, and I will be glad to answer any questions.
Thank you, Dr. Isabel. I will start by a few questions myself, and the audience, if you have a question, please raise your hand. My first question is regarding the omission of sentinel lymph node biopsy after complete response. So after a radiological complete response, you have to get a pathological complete response. You mentioned, do you do a lumpectomy or do you do a cord biopsy? Or what type of pathological complete response do you look for?
So in this study, what we are doing is that the patient is clinically T1 to T3 and clinically negative axilla, HER2 positive or triple negative breast cancer. Only these 2 subtypes. The patient undergo neoadjuvant treatments, and after the neoadjuvant treatment, we reevaluate. We do the mammogram, the axillary ultrasound, the breast ultrasound, the MRI, because in these patients we usually do an MRI also. And then if the radiologist said, there is a complete response by MRI and ultrasound and mammogram in the breast, then we offer the patient to do just a lumpectomy and not do a sentinel lymph node biopsy. But we explain the patient that if by any chance there is not a pathologic complete response in the final pathology, then she will have to go back to the OR to have a sentinel lymph node biopsy done.
So you remove the whole area of the where the tumor was?
No, we remove only the clip and a surrounding of breast tissue.
Okay. And my other question, do you clip all patients before neoadjuvant therapy? Do you clip all the lymph nodes?
Yes, we clip the lymph node that we biopsy, we always clip it, yes.
So all patients before going to neoadjuvant therapy, they get their lymph nodes clipped?
The ones that we do a biopsy and it's positive, we clip the lymph node. All.
Okay. Okay. Any questions from the audience? Please, if you have a question, raise your hand. Dr. Medhat Khafagi.
Thank you, Dr. Isabel. How often do you encounter different response as regards the primary and the lymph nodes? I mean, do you often see a PCR of the breast and no PCR of the nodes, or the reverse? How often there is
So,
difference?
so usually, you know, it mainly depends on the tumor subtype. And we usually, from the study that we had in the, that we look into the target axillary dissection, we found that in the luminal B HER2 negative patients, there were more axillary PCR than in the breast. So we see more response, complete response in the axilla than in the breast. In the HER2 positive patients, it's pretty much the same, you know. We usually see more or less the same response in the breast and in the axilla. And in the triple negative, usually we see more response in the breast than in the axilla, different to the luminal. So, you know, but this is our own data. The majority of the patients in our study respond better in the axilla than in the breast.
Why?
I don't know.
Okay.
I don't have an answer for that. But the truth is that, for example, in the HER2 positive patients, we see that the response in the axilla is much higher than in the breast. Always. I cannot tell you why is that, but we see that more often.
No, but you don't know
I don't know the answer to that. No.
How about they said that breast cancer stem cells is resistant to chemotherapy. Did you measure the percentage of breast cancer stem cells in these pathologies?
No, we don't.
You believe in breast cancer stem cells?
No, well, yeah, that is one of the theories of why the patients recur and why the patients do not respond to chemotherapy. But as far as now, I don't think there is any biomarker that can tell us which ones are the ones that respond worst besides the pathology, the conventional pathology.
Can we define in the pathology breast cancer stem cells from the regular progeny of the other cells?
I don't think so. We can do that right now.
There is no way.
No, well, they are doing that in clinical trial. I mean, in basic research, but I don't think we can do that with the conventional pathology in the clinical practice daily.
I mean that there is a marker for breast cancer stem cells, which we can depend on to know the incidence of breast cancer stem cells in the specimen.
Yeah, I don't know. I'm not really an expert on that. I know that when I was in my other institution, we were doing some studies in basic research looking at that. But I'm not, you know, I'm not sure that there is nothing now in the clinical practice or in the clinical research that we can use to define that.
Okay, thank you. Thank
you. Dr. Roa Ataya.
Yeah, thank you very much, Dr. Sham. Dr. Isabella, thank you very much for bringing this update about the axilla. It's very challenging. My question back to the cohort that you were examining, post-neoadjuvant, HER2 positive, triple negative. You tell the patient, I'm going to go ahead for lumpectomy after extensive clinical radiological assessment, stating that there is no residual disease. Yet, you operated on the lady. She started with a 2 or 3 centimeter, and now you found a focus of 3-4 millimeter. You want to bring her back to theater as per the agreement. We know that post-neoadjuvant, the sensitivity of the sentinel drops down, and that's why we are encouraging, or it's actually mandatory, it's not only encouraged, to have the dual technique, the immunohistochemistry assessment, and so forth. How will you overcome the pitfall of low sensitivity for a take back of such a cohort of patients to theater for a sentinel on a separate event? Thank you.
So the question, if I get it right, is that you mean doing a sentinel lymph node biopsy after having done surgery on a patient? Is that your question?
Yes, ma'am. The cohort you mentioned that
Yes.
they had complete radiological clinical response,
Yes.
triple negative or HER2 positive.
Yes.
You take her to theater for a lumpectomy or
Yes.
a fingerprint, and you, according to the protocol, if you found any residual, you will bring the patient back to Sentinel and
Yes.
another surgery.
Yes.
So now injecting her with dual techniques will definitely has markedly reduced sensitivity down to 40%. How can we overcome this?
But we have many studies. So in those patients with clinically negative axilla, let me just start from other side. So in those patients with a clinically negative axilla who undergo neoadjuvant treatment, and we do a sentinel lymph node biopsy, I'm not talking about the study right now, but we don't use dual tracer on those one. We only use radioisotope because, you know, if it's a clinically negative axilla to start with, we don't really have any study that show that we need to use dual tracer. So we just do sentinel, we just use radioisotope. We have enough experience and there is enough data published that in those patients who have a lumpectomy and undergo a sentinel lymph node biopsy after, you know, couple of weeks after, the false negative results of the sentinel lymph node biopsy is very low. So, you know, we have in our data enough experience and we can always find a sentinel lymph node, and there is no increase in axillary recurrences in those patients. So there is no data that show that in patients who had a lumpectomy and undergo a sentinel lymph node biopsy 2 weeks later, there is an increase in axillary recurrences. Another thing would be if the patient has an oncoplastic procedure, then doing a sentinel lymph node biopsy after an oncoplastic procedure like 2 weeks later, with all the remodeling the breast, that is probably a problem in the sentinel lymph node biopsy. In those cases, you know, in the study, we are only putting patients in this study who undergo a standard lumpectomy, whether a level 1 or a level 1 oncoplastic technique, but no level 2 oncoplastic techniques. Because we believe that if we do that, then we will probably end up not finding the sentinel lymph node if we need to take back the patient. So in the standard lumpectomy or level 1, there is no data that show an increased axillary recurrency. So in those patients, we don't have a problem with that.
Okay, and do you
I don't
still
know if
use...
I answered your question.
No, you did indeed. Like you cleared a lot of things, because it's not only in this. I'm just reflecting. We received many cases that they had an upfront lumpectomy without a biopsy, and then they come over to where I work, and it turns out to be cancer on the final pathology, and we get puzzled. How can we stage the axilla? Like if we can reflect on another scenario. My very last comment, and I'm sorry I took longer. If you're gonna take this patient back to theater again, you're gonna use a single tracer T99, or you're gonna use a seed or mega tracer or methylene blue, just to enhance your sensitivity, or you're happy with the and confident with the number that you have?
Yeah, I'm happy with the radioisotope. I wouldn't, you know, I think it will be more difficult with the methylene blue or the blue dye, but you know, sometimes in those cases, I think that the only problem in those patients is if they have a big lumpectomy in the upper outer quadrant, but you can always inject subdermal there. So, you know, I'm not much worried about that, really.
Oh, perfect. Experience does count. Thank you, ma'am. Thank you.
Okay, any other questions from the audience? I have a small question. If you have a positive axilla and then after neoadjuvant chemotherapy, you have a complete response in the axilla, how efficient is the sentinel lymph node biopsy in this axilla? Is it as safe as in? I mean, is it normal to do a sentinel lymph node biopsy in such an axilla?
Yes, if you have a complete response after neoadjuvant treatment, we have like, I can tell you that 99% of the times we find the sentinel nodes.
Okay.
Because I think that the idea that we had, like, you know, many years ago, thinking that after neoadjuvant treatments, you know, there was like, you know, problem with the flow of the lymphatics because
Yes.
the fibrosis. I think we have realized that, you know, this is not really true. I mean,
I still hear this today. I still hear this information.
But from the studies, we know it's not true. I mean, you know, the drain is as good as it can be. You know, I mean, we even do a repeat sentinel lymph node biopsy in those patients who has a local recurrence and have had radiation therapy. I mean, so I think that we have enough experience in the sentinel lymph node that that I think that some things that we thought were true, they are not anymore. And this is one of these. I think that neoadjuvant treatment is not a contraindication. It doesn't mean that you won't find the sentinel lymph node, because this thing about the lymphatics is not really true. At least the study doesn't show that.
Okay, Dr. Asma.
Okay, thank you. Regarding the cases that are clinically positive lymph node and got response to the neoadjuvant chemotherapy and become clinically negative lymph node, if you have no access to the sentinel lymph node and do sampling of axillary dissection, what is your strategy? Do you go with axillary sampling or dissection, and what's the minimum number of the lymph nodes that are sampled?
You're talking if you don't have sentinel available, right?
If we don't have sentinel lymph node access, what's the second step, or what's the option? Should do axillary lymph node dissection or sampling?
So
And
you
if
mean,
we don't,
oh, sorry. So you mean that you don't find the sentinel node, or you mean that you don't have the option to do a sentinel node because
She
you don't
doesn't
have
have the option
radiotracer?
or the
yes, we
resources.
don't have facility of the sentinel lymph node.
But okay.
Only dissection or sampling. Which is the better?
Well, I think that the sampling is like fishing. So I'm not sure that, you know, you can compare the sampling. I know that the UK, the English people do a lot of sampling. But, you know, the real thing is that the study shows it's like open the axilla and took the nodes that you think, like 3 or 4. I mean, that doesn't mean anything in the neoadjuvant setting or in the adjuvant setting, because mainly in the neoadjuvant setting, the axilla has it's more difficult to assess by palpation and everything. So if you don't have available for a sentinel lymph node biopsy, I think the patient need to have an axillary lymph node dissection. But I think there is always, you know, maybe you can use methylene blue, maybe you can use put something on the node, or a clip, or something. I think there are so many different type of tracers now that I think it will be good to try to find one if you can avoid an axillary lymph node dissection. But I think that the sampling is something that has not proven to be equal to the sentinel lymph node.
Even if the patient they will receive radiation after that?
Well, but you don't know if you are sampling the nodes that are positive or negative. So even if the patient is having radiation therapy, I think the standard treatment would be an axillary lymph node dissection.
Okay. What's the minimum number of the lymph nodes should be dissected?
Well, there is no minimum numbers. We know that that after the neoadjuvant treatment and we do an axillary lymph node dissection, usually there are fewer number of nodes than in the adjuvant setting, and that can be because sometimes if they were positive, now they are fibrosis and the pathologists do not really see them. I think that, 8 or 10, it's something that after neoadjuvant treatment, the study shows that would be enough, the 10 lymph nodes.
Okay, thank you.
Okay, any other questions? Please, if you have a question, raise your hand.
There is a question in the chat. Would you clip the node, same setting of biopsy, or wait for the positive result of the pathology? The dilemma of unnecessary clipping versus missing the biopsy node. Okay, so what we do is that if the radiologists tell us that the chances of the node to be positive is very high, then we clip it at the same time as the biopsy. If it's unclear, then we'll wait. And we don't clip the axilla, we don't clip the breast, we wait for the results, and then if the patient undergo neoadjuvant, we clip the breast and we clip the axilla at the same time. So generally, we don't do it always the same.
Okay. Do we have any other questions? Please, last call for a question. Okay. Okay, I think that was it. I think we don't have any more questions. Thank you, Dr. Isabel. I hope you enjoyed it as much as we did. Oh, wait, you're muted. Unmute.
Yes.
Dr. Roa has another questions. Dr. Roa, I have a question.
No, I'm just saying thank you very much for hosting such a very challenging topic. Thank you.
Okay, thank you, Dr. Isabel. I hope you enjoyed it. And if you have the time in the future, we can maybe do that other topic you suggested later, maybe in a few months.
Okay, perfect. No, thank you. I'm sorry because I had a cold last week and I am really kind of, getting this cough, but it's going away.
No, thank you. We really appreciate you.
Yes, thank you very much. Thank you.
Thank you. I will send you the video tomorrow.
Okay,
Thank
thanks.
you.
Bye. Have a nice evening.
Bye-bye.
Bye.
Bye-bye.